Welcome to part 3 of this 4-part continuing education series. My name is Max Dodge. I'm a paramedic in New Hampshire and an EMS instructor. This 4-part series of short continuing education topics will cover the airway, respiration, and ventilation portion of the National Continuing Competency Program topics. So we now understand the relationship between tidal volume and respiratory rate, and how there's a sweet spot for optimal ventilation. But now we have a patient in front of us with shortness of breath. How can we evaluate the patient's complaint along with other signs like work of breathing to determine how close they are to respiratory arrest? Dyspnea is a subjective feeling of difficult, labored, or uncomfortable breathing. It's often described as shortness of breath, air hunger, or breathlessness. But to get an impression of a patient's respiratory status, we use quantitative measurements, like vital signs, and qualitative measurements, like work of breathing. The combination of the patient's subjective dyspnea with more objective signs and symptoms of difficulty breathing is called respiratory distress. Respiratory distress is our canary in the coal mine, our sign of impending doom. The longer our patients remain outside the area of adequate ventilation and perfusion, the more likely they are to reach a point where oxygenation is insufficient to meet the metabolic demands of their body. This point is called respiratory failure, or sometimes ventilatory failure. This occurs when the lungs and ventilatory muscles can't move enough air in and out of the alveoli to adequately oxygenate blood and eliminate carbon dioxide. This leads to a collapse of the respiratory function called respiratory arrest. And as the name implies, we see that this patient's respiratory rate and tidal volume fall to near zero. When we take that information and display it across time, we see this roller coaster of a graph. We can see that, just like on the last graph, our patient is experiencing progressive respiratory distress until they reach a tipping point. Now, it's important to remember that breathing is exercise. Lots of muscles are involved in the process of moving air. It consumes oxygen, it requires increased blood flow, and it produces carbon dioxide. Numerous studies demonstrate that patients who haven't breathed on their own for a while, that is, patients who are on ventilators in a hospital, who are then taken off the ventilator to see if they'll breathe on their own, will suddenly experience a big spike in energy demand, big enough to cause cardiogenic shock in some cases. Once they cross the threshold of respiratory failure, we see that their work of breathing quickly collapses to zero. So what can we do for these patients now? Well, we can give them positive pressure ventilation. Positive pressure ventilation relieves the respiratory muscles, which then decreases the oxygen consumption and allows whatever limited cardiac output the patient has to serve other metabolic demands. It gives them a little bit of wiggle room to work on what's making them sick. So to recap, in this part, we define the subjective report of dyspnea and the objective evaluation of respiratory distress. We looked at the tipping point of respiratory failure, and we talked about the collapse of respiratory function known as respiratory arrest. Check out the final part of this continuing education series where we'll discuss the relationship between positive pressure ventilation and cardiac output.